going to SIADH. SIADH, well, think about what's occurring here. ADH runs down to the collecting duct in excess, and you're going to remove more and more and more and more free water. As more free water is being produced, or should I say free water is being reabsorbed, your plasma osmolarity will decrease like crazy. What's the state of my urine? Look at the statement here. What's the state of my urine? Hyperosmotic urine. Urine. Remember I told you whenever you deal with osmolarity, always pay attention to the adjective. Is it my urine compartment or is it my plasma compartment? Problem here, too much ADH. Circulating levels of ADH abnormally high. How may this occur? Pay attention here now. Head injury. From henceforth, head injury. Do not think that you have destroyed the posterior pituitary, resulting in lack of ADH. Many students do that, and they get everything wrong. Either in clinics, they make a fool of themselves, or on the boards and get the questions wrong. So, from henceforth, when you have a head injury, it can be rather unpredictable. So what do? You base your question on the labs that are given. What does that mean? If there's head injury and you find your plasma osmolarity, listen, you find head injury and you find your plasma osmolarity really low, and you find your urine osmolarity really high, what is your patient suffering from? Release of too much ADH from the posterior pituitary. What if we do the opposite? I'm going to throw in a mix here. What if you find on a lab that your urine osmolarity is really low and your plasma osmolarity is really high? What's your diagnosis there? Central diabetes insipidus. Are you seeing this now? So be careful with head injury. Do not always think that you exhaust all of your ADH. In fact, you might release too much. Where else could ADH come from? Lung tumor. Which one? Small cell or squamous cell? Good. Small cell. Paraneoplastic. ADH secreted autonomously without an osmotic stimulus. That could also occur. So there's no osmotic receptor that's telling the ADH or posterior pituitary to release, or from the hypothalamus, but you're autonomously releasing it. ADH is secreted when it's not needed. So, generally speaking, important clinical situations, head injury, and perhaps your small cell lung cancer, and the fact that you might have autonomous secretion. The level of ADH increased reabsorption of water from the distal tubule and CD collecting duct. You have hyperosmotic urine. Stop. Hypoosmolar plasma. Clear. 2 compartments for osmolarity always. Keep those compartments separate. Keep them organized so that you have proper differentials. Hypoosmolar plasma inhibits the secretion of ADH. It should. Listen, normal individual. Let me give you an example. Drinking too much water right now. All right, drinking too much water. What is your plasma osmolarity? Decrease. What should it do normally? Suppress my ADH. But what if it doesn't? Then we have SIADH. The feedback inhibition in SIADH, syndrome of inappropriate antidiuretic hormone, does not occur because ADH secretion is now autonomous. How does this occur? Well, I gave you a prime example. Head injury, maybe small cell lung cancer, so on and so forth. Now, what about management? Well, dimethylcycline inhibits ADH action on the renal principal cell. So we have dimethylcycline inhibits ADH action on the renal principal cell. There's something that may behave like this on purpose. The other big one would be something like lithium. Lithium and dimethylcycline actually induces nephrogenic diabetes insipidus. So let's step back here and make you understand what's happening. SIADH is your primary pathology, and this is how the questions and the stems and the things that are worded may confuse you. If you're not paying attention, you're going to choose the wrong thing. Please, just let me walk you through this. Your patient initially has come in with SIADH. You know that because of the labs that they have been giving you. An increase in urine osmolarity, a decrease in plasma osmolarity. Fantastic. You know your patient has small cell lung cancer, most likely chest x-ray, next step of management, and you try to look for that cancer, small cell lung cancer, that might be paraneoplastically releasing your ADH. Okay, fantastic. Now, with all that ADH being secreted into circulation, it has excess activity on your collecting duct. Excess activity on the collecting duct. Would you tell me a step of management in which you are introducing a disease, quote unquote, to deal with SIADH? Well, if ADH works in the principal cell, why not give a drug that is going to impair the action of the principal cell? Why not give a drug that actually kind of, knocks out the ADH receptors? What are those receptors? V2 receptors on the kidney. Amazing. So here, you're going to induce, what's nephrogenic mean? The V2 receptors aren't working. You're going to induce nephrogenic diabetes insipidus in a patient with SIADH. How might you do that? Demiclocycline. Now, that's one of those tetracycline drugs that might do that. Lithium could be a little interesting. With lithium, yes, it may then cause nephrogenic diabetes insipidus. Now, is that something that you want to use in a patient with SIADH? Well, just keep that in mind, because you want to keep as many angles as possible so that you're open to possible questions coming at you in any direction. My job here is to give you as many angles as possible. At some point, where I will talk to you about lithium is going to be how you have a bipolar patient taking lithium, therefore resulting in nephrogenic diabetes insipidus. Not so much treatment for SIADH. Demiclocycline, sure. Treatment for SIADH. Keep that clear. Make sure you review this. I've given you a bunch of information here that could be rather confusing, a lot of terminology, but understand the topic at hand and deal with the management, and you'll be in good shape.